The foundational piece, of course, is having the adequate provider and nursing staffing, right? Safe staffing and appropriate staffing. That's kind of a given, but it's assumed to be a given, but not always available, but that is key. And there's a couple of things, honestly, having worked over the years on some of the national playbooks for ER efficiency, things that we've determined have the greatest consistent impact on any ER, no matter what size you are, no matter what complexity it is. Because you have ERs in small rural hospitals that may be 10 beds. I've worked in ERs and run ERs that are 60 to 70 beds that are trauma centers. But some of the basic foundational things that work consistently are these three things that I've kind of thought through over the last few years. One is making sure you get people's care started. So making sure what we call the arrival to greet, getting a patient in front of a provider in the most timely manner and being focused on that time and having the resources up front to do proper triage is critical, because the sooner you start care, no matter what research you read, the sooner you start care, the sooner you can actually move them through the ER. The second thing we found in pretty much every ER around the country that I've worked in is something called the vertical 3 space. And that is, as over the years, we've seen a bit of a drop off in express care patients, meaning those patients that used to be known as urgent care, level 4 and 5 in the ER world. We've seen that number decrease. There's been an increasing need to manage slightly more complex patients. These are called level 3. We call them vertical 3 because they're the ones that are sitting or standing. They're not severe enough to be laying on a stretcher. And so these are patients that make up anywhere from 50 to 60% of your total ER volume. And that's where you want to focus your energies, because it will have the greatest impact on reducing the length of stay in your ER. So we did a lot of work in the last 10, 12 years as I was opening ERs and running them across the panhandle of Florida around designating a specific space in the ER that is vertical essentially only. So it's just set up with these large recliner chairs. No, you only have one gurney for when you need to do an abdominal exam. And then you specifically assign adequate, if not over-assigned, provider and nursing resources, and having the lab and radiology support you need to move and address and focus on that group of patients. Because statistically, if you can move that 50 to 60% through more quickly and more efficiently, you will impact the whole length of stay of your ER, because that's where your biggest number is. The third part of that is how do you get folks out the door, right? So the third part of that triad would be what we used to call, people call a flow coordinator, or we used to call the air traffic controller. And that's a nurse, experienced ED nurse, usually in a manager role, that is really focused only on removing barriers. They're not tied up trying to start IVs or calling social workers, they're somebody that just are tracking that board all the time and looking for unfinished CAT scans, unfinished labs, consults that haven't been completed, and all they do is remove barriers all day long. And that person working, especially around the vertical 3 space, is invaluable. And in those EDs over the years that we used that model, we had significant improvement in our length of stay across the board.